To localize. When you're crossing the street, how do you cross the street? You hear the car coming first, right? And then you turn your head to see it. So very important in school for them to assess your child's auditory processing ability. Typically the child has to be 7 years old to do that and also have a normal IQ. So if your child has a below average IQ or is younger than 7, they probably are not qualified yet or can have this auditory processing assessment. It's also really important for learning how to read, because reading is primarily a function of learning the sounds first before you learn the letters. If your child has poor auditory processing skills, learning how to read is going to be very challenging. So that is another reason why the school has to conduct this assessment. The school is definitely going to tell you, we don't do that here. So what are you guys going to say? Find someone who does. That's right. You may have this covered by your private insurance. I have found that school district audiologists, many of them typically don't really understand this too much. So if you have the coverage under your insurance policy, or you can afford an independent audiological examination, it's worth the money. I think it's about $900 to do that locally. That's just your temporal lobe, that's your auditory cortex. So it's just to tell you that it's important if you have any kind of temporal lobe epilepsy or if you've had it removed to look at the audiology piece. Just quickly, these are all the different types of things you do with sound. Dichotic listening, I explained. One conversation is here, another conversation is here. Your brain is able to filter that out. What's the loudest environment with the most noise that you can think of? Playground, kindergarten classroom, those kids are loud, there are a lot of voices, and if your child has a difficult time with dichotic listening or processing sound, it's going to be really hard to learn in a loud and boisterous environment. And what we're doing here is priming the school to understand that intensive instruction, reading interventions, those kinds of things should be done in a quiet room outside of the loud classroom. This is easy. Everybody's probably heard of a gross motor assessment. This is what your physical therapist does. They're really going to look at large body movements, jumping, kicking, coordination. Most schools tend to do this pretty well. I think for us with hemispherectomy it's really complicated, but I so far have been pretty happy with the schools can do with that. Fine motor is small, the small muscles of your hand. You want to look at your child's grip strength. That should be assessed in a fine motor assessment. Pressure, how they write, whether they have dysgraphia, so some children may have trouble forming letters correctly. You want all of this picked up in that fine motor assessment that's typically done by the occupational therapist. Definitely after hemispherectomy. In the unaffected hand, you're going to have grip problems and you're going to have problems with writing. So something for them to look at. Speech. My son doesn't talk, so obviously a speech assessment is going to reveal that. Those of you who do have children who are verbal, partially verbal, you still want to have a speech assessment because you want to understand their receptive speech, what they understand in terms of vocabulary, and then how they express themselves, how they articulate. And I've circled pragmatics because many children with epilepsy, many children with intellectual challenges have trouble with pragmatics of conversation, and that is the give and take of everyday conversation. When do you say something? When do you say hello? When do you pause to give the speaker a chance to respond? These are the things that affect how you make friends as you get older, and they affect your ability to get a job. If you're unable to engage in the normal everyday conversations that you have with other human beings, it can impact your life in a pretty significant way. So even if your kid can talk and talks pretty well, you really want them to look at pragmatics of conversation. So, hopefully they can work. Augmentative assisted communication. Even if your child speaks, they may need some help with communicating their needs depending on their intellectual level. So you want them to look at their speaking ability as well as their writing. Some of these kids don't write well, so the augmentative assistive communication device can help them with that. This is a separate assessment that the school should conduct. Assistive technology. An assistive technology assessment can reveal what your kid needs to kind of help them in school. And assistive technology can be something really basic, like a timer to help them understand when they should stop studying or when they need to get a break. And it can be something extremely complicated, like an iPad for communication. My son's on an iPad with a special app for communication. All this is going to be fleshed out in an assistive technology evaluation, which you're entitled to have.
Or you become amnestic, like patient HM. And so we actually put in the RNS in him, and his seizures are now better controlled because of that. But again, he's a surgical failure in a sense, but we reevaluate it. So not every single person can have a repeat surgery, but RNS is certainly an option. And the third patient, actually, same scenario, had a temporal lobectomy, but the surgeon left this part of the brain there called the superior temporal gyrus, and then we monitor the patient, and it turned out that the seizures came from the same side. We actually didn't put in invasive electrodes, but we thought that the risk of cleaning out all that scar tissue was so low that we're not going to put in the depth electrodes. And we got this whole side cleaned out. And again, she's been seizure-free for about 6 months now. She was having fairly frequent weekly seizures. So there are things you can do. There may be things you can do after a surgical failure, but it doesn't mean that this is the last thing you can do.
The scar tissue part, because there's the two reasons why, or many why I'm not able to have repeat surgery, because I would lose more sight or become completely blind in my motor or visual skills and whatnot, and I have multiple foci. But is it and the depth, because they started when I was a day old. So what would you would you even consider trying to clear scar tissue out if you were to do those little needles, or what would your thought be?
It depends on where the seizures are coming from. If the seizures come from areas of the brain that is important for vision or speech, then we will probably put in the RNS in those areas. But that's an assumption. I mean, remember this guy who had surgery at Barrows with multiple, with two lesions, right behind the motor cortex, and we thought for sure that the seizure had to come from that area, and we won't be able to do any more. But the seizure actually came from the hippocampus. So.
Something else that I heard at a conference in Toronto made me think about the hippocampus for myself. So that's why I'm just curious about that.
I mean, there's no free lunch. I mean, any part of the brain you take out, essentially you can't have some sort of, deficit. But the question is this risk, and this is it worth it kind of a question, right? Is the mild amount of, especially non-dominant temporal lobe, people tend to do pretty well. Even dominant temporal lobe, if there's scar tissue there already, you can't make people worse. And so therefore, that's a discussion you should be having with your doctor.
If you implement the RNS for the subjects who have the temporal lobe, what effect does that have on memory?
Very little. In fact, they've now done studies on cognitive studies on people with RNS, and there's very little side effects in terms of memory. There's, because you're not taking anything out, you're actually just stimulating these structures. There's really no side effect on memory cognition.
How many sections can the RNS go into? Just two. Okay.
Two. You can have 3 wires implanted, but only 2 can be connected with the current system. Okay. Now the other thing that we've done is that we actually, if somebody who hasn't had surgery and the seizure comes from both hippocampi, we actually have, let's say if 90% of the seizure came from this side and only 10% came from this side, right? majority came from the right side. So we actually have done a resection of the 90% side and put in the RNS for the 10% side. And that makes up, that for us actually we've gotten better seizure control than we just putting bilateral RNS.
Is that something that you can tell from the whole workup coming up to the surgery?
We actually record many seizures while the patient's having intracranial monitoring, just to figure out what is the right proportion. One of the things that we discover more and more is that a lot of patients are actually having bilateral seizures, because if you're just in the epilepsy monitoring unit and just getting monitored, and then your doctor reports 3 seizures, then how do you tell the 4th one then come from the other side? So it's all a sampling issue. We try to sample reasonably as many seizures as we can. Usually you need about 5 seizures trying to figure out whether or not one side is really consistent. The old school was like 3 seizures, but really you need more than that trying to figure out whether there's consistency or not.
You discover that there is something like this happening within your family anywhere, then it makes good sense that you have genetic testing, so carrier testing of other members of the family to figure out which line through that family those mutations are passed on. Because then, if people know whether they're a carrier or not, that will inform their decisions about having children later in life.
But there's no way to change the gene mutation of the parent so then they're no longer a carrier.
No.
Okay. Gotta ask.
That's not possible as yet.
Yeah.
That's one of those things that in those newspaper reports was tantalizingly dangled that it might be a possibility one day out there in science fiction land. But we don't live in science fiction land yet.
Over by the entrance.
And we're trying to figure out what we can do.
Hello, Mickey.
With current technology. Yeah. And with current technology, I know that people will be working on ways to try and correct those defects in a mouse. We know that it's possible to correct defects in cells on a dish, but will it be possible to do that in a whole brain?
Yeah.
We don't know as yet. And those are things that become exciting possibilities as technology comes along. We also have to be very wary that they have their ethical implications as well. So having the ability to manipulate cells, or for example, use stem cells, these things all come at a price, and we have to consider which is the best, sensible, and most ethical approach to do any of our science as we move forwards. And a very interesting ethical question that has come out is that obviously knowing about these diseases at a very early stage would be best, because our chances of treatment are much highest if we know about them early, which raises the whole question of newborn screening. But see, for example, you can't really screen for something in a newborn if you don't have a means of treating it. That's a very difficult ethical ground to be on. You could screen everybody for every mutation, but you would not know if you don't have the ability to do something about it. That's not a world I wish to be living in. So now, with CLN2 disease, we actually have the ability that we can intervene, and there is an FDA-approved therapy. So it raises the question whether screening for CLN2 would actually be a sensible thing to do, and whether that is something which is now feasible. There are lots of implications to come out of it, because in that screening process for CLN2, we might find that particular family had CLN1, and we can't currently treat CLN1. So it's kind of a chicken and the egg situation. We're kind of catch-22. We're in a place where we can do some things, but we can't do other things. And that makes it quite complicated. I mean, certainly where we are now is a much better place, that we actually have something that we can intervene in one of these forms of the disease, which is certainly very different from when I started a number of years ago. We clearly have a lot more work to do to get to the same place with all the other forms, and that's what we're actually doing. So you asked some questions about a variety of different drugs or compounds that you might use to intervene, and in some of those situations, for the forms that aren't a Pac-Man, for the forms that are, if there's our lysosome, the thing that's sitting in the wall, Now, if we knew what that did, what molecular pathway, what biological process inside the cell it worked in normally, we would be able to do something about fixing that problem. But despite many people much cleverer than me working on it for many years, we still have not a lot of an idea about what that normally does. And if you don't know what it normally does, it makes it very tricky to figure out how you're going to fix it. So what people do is they look at a model that has the same mistake, and they look at all the possible things that are happening in that model. So some of those things will be really important things, and some of them will be like a cascade of badness that's trickling down. And some of the things you might identify and try and treat with a drug, you say, oh, I see that there is a problem with mitochondria, and treat with a drug that you know might have a positive effect on it. Or you might look at them and say, there's oxidative stress going on, and try to block that. Or we've done a lot of work looking at the brain's immune system. And so we treat with anti-inflammatory drugs, or we treat with immunosuppressant drugs. Now, all of those, if they're a long way away, if they're something that affects way downstream of the original problem, they may have a small positive effect, but they're not addressing the underlying cause.
You can have epilepsy of one entire half of your brain, and we do surgery for that. We take out half of the brain. So it really is something that is very specific to each person. You know, there's no two epilepsies that are the same.
What's the best situation to use the gamma knife technique?
So gamma knife, the question is, when do you use the gamma knife? So the gamma knife is right now, it's not really, the best use of it is when you have mesial temporal sclerosis, so a type of temporal lobe epilepsy. So in doing that, it saves any kind of open surgery. That would be one use for it. But in general, if you were to say, you know, is that a good option, I would recommend in the setting of, for most people, one of the other options is a first line over doing that surgery.
So when you have the RNS implanted, you maintain all of your neuro status as the same it was before?
Yeah. So the question is, if you have the RNS implanted, do you maintain the same level of your neurocognitive status? And the answer is yes. The device doesn't do any, you know, it's not resective, it doesn't change the brain other than to shock that area. And sometimes we see that people's seizures go down just over time. But overall, it doesn't have any long-term major changes to people. Now, with that being said, you could make that same argument for a lot of people who have temporal lobectomy or resection or whatever, because a lot of those people, they are very similar to how they went to sleep, or the same. So it's not just RNS or VNS that does that. Any other questions?
I have a question. How many people that have RNS end up with still being on medication? What percentage?
I would say probably most of them do. RNS is not I mean, like a pacemaker, a lot of people who have pacemakers still have to take some kind of heart medicine, because it's an additional step. It's not the only treatment. It's one of several. With the laser, you can, yeah, in certain cases. Same with resection. Same with that, yeah. I mean, with a VNS and RNS, very unlikely. But with resection, ablation, laser we talked about, DBS possibly in the future, and then gamma knife as well, same kind of thing.
But you won't have to be on as many?
Again, it's hard to say. That's not 100%. There are people that don't respond, and so it's one of those things where it kind of depends on how you do with it. I would say though that in my experience, the patients we've operated on, we've done a lot, and those patients do very well. I say that a lot of some patients we implant the electrodes, and the device we leave it off for about a month. And even while it's off, their seizures go down just from the implantation. And I've had patients where 8 months go by and they don't have a seizure, and all they have is just the implantate. It's not even turned on yet. It's something about the implantation effect. So just having those leads on that part of the brain, and that irritating or that doing whatever it's doing to that area is enough to sometimes decrease or stop seizures for a long period of time. Similar to when you take a new medicine and your seizures go down, honeymoon period, similar to that. It's very similar.
You said that seizures, of course, cause the brain to change, right? And I was wondering, since the VNS and the RNS, they send stimulation, I was wondering if the stimulation causes different changes. Would that be positive or negative? I mean, it should be positive, right?
So it's a great question. So the question was, if you have vagus nerve stimulation or responsive neurostimulation, and it's sending these shocks to the brain, does that change the brain? Does that change the connections? And if so, is that good or bad? And I think, that's a very good question. And it's a hard question to answer because we really have we're still learning a lot about how these devices work. Now, with that being said, in general, the vagus nerve stimulator that's thought to be how it works. So by stimulating the vagus nerve, that causes some sort of changes in the brain connections. And over time, we see that people sometimes have seizure reduction related to that, those changes in the connections in the brain. Same way with the RNS. Over time, if it sends these shocks or it's changing the way the seizures are treated, we can see sometimes people have reduction in their seizures. Now, it may be that the device is shocking the brain and that's stopping the seizures from, going forward. We don't know that, but regardless, the brain does have some changes that occur when you get stimulation.
30 to 45 minutes. He has zero muscle control. He can't look at you. He can't anything. It takes about 45 minutes to an hour for him to even be able to focus, and it takes him an additional 24 hours to be able to have 50% motor control, and then another 48 hours to get to like 75%. So, I mean, the after effects are very traditional, they say, of seizures. His seizures aren't super dramatic, at least the ones that we've seen, but they are exactly the same every single time. And they're nighttime, except for the 2 to 4 that we have just started happening during the day. But we just kind of don't know, like, where do we go next? We are trying to get transferred over to the group that specializes in seizures, so maybe we'll have more information there. But we get so much different information from everybody.
It's hard, right? Because that's the one thing in epilepsy we don't agree on very much. It's hard to get us all to agree. I mean, it's hard without actually seeing the information, but genetic testing probably needs to be done. Microarray is just like a cursory overview, like it's looking at genetics from an airplane, not like right down in the lamp. So you need the actual epilepsy genetic testing. If you can get a diagnosis, then that's going to give you the answer, right? Because that tells us exactly what we need to do. So that's definitely something that you need to do. And then the EEGs were completely normal.
But he's not during a seizure.
Right. Yeah, it makes it a little harder when there's not a seizure. I mean, probably not having heard everything exactly. It's probably sometimes when we have seizures, even if the EEG is normal, we try treatment to see if we can get things better. So that's probably the next best step, is to try some type of treatment that would be right for the seizure type we think we're having, to see if we can stop the regression that you're seeing after all the seizures. But genetic testing is probably the next best step, to try to get an underlying answer to see if we can figure out what's going on.
It's been delays ever, so he was ahead.
We don't know. Yeah, and she was too, and we don't know
There's
why.
a lot of genetic diseases where you have normal development and then you lose. I mean, that's the classic for Dravet's, with normal development and then loss of development. And people. Yeah, I mean, people don't understand if you're born with a genetic disease, how can you have normal development and then lose it? But that's the hallmark of some of the genetic diseases, that you're actually, that's the criteria for meeting the genetic diseases, that you have to have normal development till a certain age and then you lose your development. There's some diseases where you're normal till teenager, and then that's when the disease hits you, and that's when you lose your development and have your bad epilepsy. So just because we say it's a genetic disease doesn't mean you have symptoms at birth. There's genetic diseases that present across the lifespan. So it's not, just because you're born with a genetic disease doesn't mean you present when you're born. You can present throughout the lifespan. That's just the way genetics is. You can present at any time. So the genetics is changing the way we practice medicine. It's really the most important thing in epilepsy right now is genetic testing and these genetic diagnoses. The way it changes for Dravet's disease, for example, Dravet's is an abnormality of the sodium channel. And it's a very interesting disease because kids present initially with febrile seizures and then they have focal seizures. And when you have focal seizures, the medications for people who have been in the epilepsy world for a while, you think of medicines like Tegretol and Triliptal. Those are our kind of mainstay focal drugs. That's why they put your child on Triliptal, because it's a focal drug. If you give somebody with Dravet's Tegretol or Triliptal, you put them into status, which is a really bad thing to do. But they have focal seizures, that's what you would normally use. So if you don't have genetic testing, you by mistake, trying to do the right thing because they have focal seizures, put the child on the completely wrong drug and actually cause harm because you put them into status epilepticus, which is life-threatening. Whereas if you had the genetic testing, you would have completely avoided those drugs because you knew that's not the drug for those children. The other disease that genetic testing really changes is glucose transporter. So GLUT1, I think there's a table down there for the GLUT1 patients. These patients have a defect in the glucose transporter gene. They can't get sugar from their blood to their spinal fluid, so their brain is starving for sugar. And those kids have to be on the ketogenic diet. No medication works at all. Their brain needs another source of energy. You put them on the diet, they switch from using sugar for energy to using ketones for energy, and then their brain works just fine. And instead of having intractable seizures, they do great. But you have to be able to diagnose that. So without genetic testing, you don't know these things. And you may not get to ketogenic diet until they failed 5, 10, 12 drugs, when that was the treatment they needed. So genetic testing makes a big difference.
Spinal tap,
yeah, so you can see a low sugar on the spinal tap. That's like the red flag. That's the warning if someone thinks to do a spinal tap. But not everybody thinks to do it in new onset seizures. And sometimes it's not as low as you think. There's some patients who have a defective glucose transporter. It's not 100% wiped out. It's just partially wiped out. And their CSF glucose is actually pretty close to normal. So, yeah, there's a new form. So now that we have gene testing, we find all these new things. So the classic glucose transporter defect presents in babies. And they seize right away in the first few months of life. There's now a variant where they present as teenagers. And instead of having neonatal seizures, they have generalized epilepsy as teenagers. And they have, instead of a complete absence of the transporter gene, is just defective. So it's a little slow getting across. Some sugar gets across, but not enough. And those patients present later in life, but they still have the same gene defect. So it's another disease that you wouldn't normally think about. So they have what looks like straightforward absence epilepsy, which is usually an easy seizure type to treat, but they don't respond to drugs. You put those patients on the diet, seizure free. But you wouldn't normally think about that, and nobody would probably do an LP on a normal child presenting with absence seizures, right? That's like an easy treatment. We don't usually tap those kids. But we now genetic test almost everybody. If they don't have a known diagnosis, we're genetic testing everybody now.
How often do you change that's changing?
Oh, almost every time. So almost every genetic test changes what,
Right, so is it like every 6 months? My kid doesn't have a diagnosis. She's epileptic, but we have no cause. So do you test her every 6 months?
Yeah, so everybody without a cause gets genetic testing, and then our lab automatically rescreens that DNA whenever new genes come out. It's done automatically by the lab once they have the DNA. So you don't have to submit another DNA sample. Right, so in every genetic lab should do that. So before you give your DNA to a genetic lab, you should ask them. Because what we had just happened recently, it can go both ways. So what happens is when you get genetic testing, it's actually really complicated. So some genes come back truly abnormal. So this is definitely disease causing. Some come back, this is completely benign. And then most of them come back saying, I don't know what this is. This is something is abnormal, but we don't know what it means. We don't have enough information yet. And those are the hard ones. Then you have to look and say, well, does this disease fit what the child presents like, or does this not fit? And then the doctor and the geneticist have to try to figure it out. And sometimes we look and see what it's doing to the protein, what it's doing to the body. We say, yeah, this looks like it's disease causing. It fits what my child has. I'm going to assume this is real. And then sometime down the line, 6 months later, a year later, 3 months later, then they'll say, okay, now we have enough information in the world to say this is disease causing. Or they'll come back and say, okay, this one's been ruled benign. And that can make a big difference. We had a family recently where it was a Dravet's family. She had 2 mutations in the Dravet's gene. We didn't know which one was disease causing. The father carried one and they wanted to have another baby. So about a year after the testing, the lab came back and said, oh, that one the father carried has now been classified as benign. So now they can have another child, not worried about passing that gene down. And the lab just does that automatically. A good lab does that. Not good labs don't do that, but that's important to know whether it turns into disease-causing or benign. Either way, you want to know.